evening, ladies and gentlemen. I'm Dr. Nair, Head Department of Cardiology, PRS Hospital, Trivandrum. Today we will be talking about the gist of heart failure presentations from day one from Prague as to what important things were highlighted today. The first interesting trial that came out was on a new molecule called trientine hydrochloride. Trientine hydrochloride is a new molecule tried for heart failure, as you see there, with reduced ejection fraction. The TRACER HF trial. This trial was presented from the Bain Institute of Clinical Research, Boston, Massachusetts, on behalf of the TRACER heart failure investigators. Now, here's the background. Copper, the element copper, is an essential trace mineral with important roles in myocardial function. If it is above normal, it's bad. Below normal, it's bad. So it's important that copper levels are normal, ideal in the myocyte. And depletion of copper in the myocardial cell is known to cause myocardial remodeling. Trientine hydrochloride, the molecule we're talking about, restores and normalizes intracellular copper, and people try to look into, does that change the scenario of HFrEF? So a copper modulator, trientine hydrochloride, and its effect on HFrEF, heart failure with reduced ejection fraction. This is how the study design went. HFrEF, patients of 200 patients were randomized. One group, as you see there, 300 milligrams of trientine hydrochloride twice a day. One group on 150 twice a day, 50 twice a day, versus a fourth arm of placebo. So on one side of placebo, you have trientine 50 milligrams BID, trientine 150 BID, and trientine hydrochloride 300 milligrams BID. Now, this is exactly how the trial went. You have the screening, the randomization, week 1, week 2, and the analysis was done at week 4. Right, at week 4. Let us look at the data. The primary endpoint in this trial was the NT-proBNP, the biomarker NT-proBNP looking into cardiac failure. On the left, you see the LS mean ratio of NT-proBNP. Let us put a line straight at week 8. On the top, the blue line is placebo. NT-proBNP is kind of flat, it's not reduced. But the yellow line of 300 milligrams BID dosage of trientine hydrochloride significantly reduced NT-proBNP compared to the placebo. If you look at the data from a geometric mean ratio, a different kind of analysis, on this table on the right, you see a similar data, 300 milligrams BID of trientine hydrochloride producing a much lower level of NT-proBNP. So compared to placebo, trientine hydrochloride reduces NT-proBNP. But the question is, what about left ventricular volumes? Does it change the LV volumes? Now, on the left, you have placebo. The blue bars are end systolic volumes, and the red bars are end diastolic volumes. Now, look at that. LV volumes, 50 milligrams, that is the end systolic volume, significantly down. 150 milligram BID, yes, similar trend. 300 milligram BID, similar trend. So, trientine hydrochloride in different dosage ranges reduces end systolic LV volume. It also showed an improvement of 6-minute walk distance with trientine hydrochloride. So at conclusion, this presenter said that among study participants with HFrEF, heart failure with reduced ejection fraction, you have addition of trientine hydrochloride reduces NT-proBNP at 4 and 8 weeks, favorable trends on reverse remodeling, 6-minute walk distance, and KCCQ, the symptomatic score. And finally, further studies are clearly indicated to show benefits and role of trientine hydrochloride, the copper modulator, in heart failure with reduced ejection fraction. That brings us to the next interesting presentation. Just a presentation with a philosophical touch by none other than Professor John McMurray. John McMurray from Glasgow presented this set of slides, very interesting, trying to show us what happens in our clinical practice in real life. Right. Look at the data. On top, you have what is called the conventional therapy of heart failure with RAS inhibitors, ACE or ARB, and a beta blocker. And compared to that, In real life, say you have conventional therapy, the comprehensive therapy, meaning conventional therapy, plus an ARNI, an MRA, and an SGLT inhibitor. So you have RAS inhibition and beta blocking. And then you compare that with ARNI, MR, and SGLT with the beta blocker, the standard 4-drug regimen, right? And this is what you see. Look at the graph. On the y-axis, you have event-free survival. On the y-axis, you have age. Look at that. The age starts from 65. So Professor Macleods tried to show how far you benefit in a person with 65 years of age when you start therapy, right? Look at the data. This is the standard conventional therapy graph, and that is the comprehensive therapy. Significantly better outcome, significantly better event-free survival, right? Now look at the data. Conventional therapy gives a event-free lifespan of 6.5 years. Comprehensive therapy, a massive 13 years. So you gain some kind of 6.5 years of event-free life if you prescribe a comprehensive therapy instead of a conventional therapy. This is common knowledge, but the way Professor Macleods presented it was really, really fascinating. He also showed that how important it is to implement such therapy. We know the benefits of therapy, implementing them in real life, and they have been published as 2 editorials on the same issue in JACC and Circulation. So this is what he also said in a philosophical note. Think of the difference that you would make, even for one single patient. For example, even for one single patient, if you had written a proper therapy each day, how much of difference it would make? How much difference it would make if you had started treatment earlier, right? And if you can't, who can? Are your patients involved? A very, very philosophical presentation. From there, we had again another fascinating presentation, the Philip Wilson lecture, labeled beautifully Spirals, Paradigm, and the Progression of Heart Failure by Dr. Piotr Bonikowski from Poland. And in this presentation, he tried to highlight many things, and this is one that caught our eye. Interesting, right? Interesting. Here, he tried to show the iron deficiency in heart failure. Now look at that. If you have acute heart failure set of patients, and if you look at those whose iron status was preserved, right, that is on the left. Okay, and on the right, you see that about 30% of patients have what is called an isolated high soluble transferrin receptor. Now, a high soluble transferrin receptor indicates that there is very clearly low intracellular iron. They looked at low hepcidin, isolated low hepcidin was there in about 20% cases in acute heart failure, which indicated low iron stores. Okay, right. So 30% isolated high soluble transferrin receptor levels indicating low cellular iron, and an isolated low hepcidin indicating low iron stores, right? And a set of people, like about 50%, had combination of both, right? So about 30% had isolated high soluble transferrin receptors, about 20% had isolated low hepcidin, and about 50% had combination of both. So about 75% of patients had some kind of iron deficiency by these new markers, right? And if you combine them, it's interesting. On the left, you see those who had preserved iron status. They had no one died in 1 year. So those who had a preserved iron status, which means they had a normal soluble transferrin receptor, a normal hepcidin, no one died in 1 year. But in contrast, you had any of those signs of iron deficiency, isolated high soluble transferrin receptor, or isolated low hepcidin, there was a 41% of the patients died in 1 year time. Very, very interesting. And that brings us to the next interesting practical presentation by Dr. Rossano on how to implement guidelines. We know the guidelines, right? But how to implement them in clinical real-life practice. Dr. Rossano showed the guidelines first, that we know that we have to start treatment with ARNI, beta blocker, MRA, and SGLT inhibitor, DAPA or MPA, and of course loop diuretic if there is a fluid retention. There's a standard. If the ejection fraction is less than 35, patient is still symptomatic and your QRS is narrow, you think of, does my patient need ICD? Ischemic class 1, non-ischemic class 2A. Right, if the ejection fraction is more than 35, start thinking, is it okay? But does it really need a device therapy? And if he is in sinus syndrome, ejection fraction less than 35, and the QRS is broad, more than 130 milliseconds, you think of CRTD or CRTP, right? That's how the algorithm goes. But he said in clinical practice, it is different. Like clinical practice, you have patients who are on SGLT inhibitor, DAPA or MPA, with a diuretic if congested. And then you think what category he belongs. If he has an ischemic heart disease, think of beta blockade, calcium antagonist, ranolazine, trimetazidine for the ischemia, right? If he has atrial fibrillation, think of Trivandrum. Think of pulmonary vein isolation procedures. If your patient has type 2 diabetes, think of GLP-RAs, metformin, fentanyl. Already patient is on SGLTs, right? If your patient has arterial hypertension, think of ACE, ARB, ARNI, indapamide, debivolol, beat blockade, MRA, and calcium antagonist. Patient has obesity. Think of semaglutide, right? If your patient has COPD, think of putting them on beta blockers plus LAMA or LABA, right? And finally, iron deficiency, ferric carboxymaltose, current iron deficiency, right? So the clinical feature of presentation of heart failure is different from what we read in the guidelines. That was a fascinating presentation. So in conclusion, he said that the 4 fundamental therapies need to be thought about. We should not forget about the 4 fundamental therapies, the MRAs, the SGLT inhibitors, beta blockade, and the ARNI. Think of simultaneous initiation in hospital as early as possible, because these are life-saving medicines. They act quickly and they should be started in hospital. And finally, in HFpEF, SGLT should be started without delay in all patients. So that is his conclusion from his presentation. Take home. One more interesting data that came out was with ARNI in preserved ejection fraction. That's called Paraglide HF trial. Paraglide HF trial is very interesting, where ARNI was used in patients who had heart failure with mildly reduced ejection fraction or heart failure with preserved ejection fraction, defined as a EF of more than 40% with a recent worsening heart failure event. So ejection fraction more than 40, so you don't have HFA with a recent worsening of heart failure event. And these patients, 466 of them in Paraglide heart failure trial, half of them were put on sacubitril valsartan ARNI, and half of them comparative on valsartan, just an ARB. And of course, the endpoints, the primary endpoint was a time average NT-proBNP. What was the change of the biomarker NT-proBNP? Secondary endpoints were hierarchical endpoints, which we call as win ratio, cardiovascular death, heart failure hospitalization, heart failure visits, urgent visits, and of course, change of NT-proBNP. And finally, the safety outcomes. We have hypotension, hyperkalemia, worsening renal failure, angioedema. The safety measures, right? And they were the secondary endpoints. Now, if we look into the outcome, primary endpoint, which was the NT-proBNP, we see that yes, the sacubitril valsartan in blue did better than plain valsartan, right? At week 8. So the biomarker rise was lesser. So 15% greater reduction of NT-proBNP with sacubitril valsartan in people with ejection fraction more than 40%, with a p-value of 0.049, right? Now, the secondary outcomes, we call them as win ratios. Win ratios where overall, you see the blue bar, sacubitril valsartan, red valsartan, and gray is where there was a tie. So when valsartan sacubitril won, it was blue. When valsartan alone won, it was red. So you see the win was much more with blue. Overall, take cardiovascular death, heart failure hospitalization, urgent heart failure visits, change in NT-proBNP in every category. The blue bar has beaten red, hands down, right? So you have sacubitril valsartan winning in almost every single category. So in summary, they said in a diverse population of ejection fraction, more than 40% on sacubitril valsartan compared to valsartan, you see greater reduction of NT-proBNP. At 8 weeks, you have a greater reduction of NT-proBNP. You have a tendency towards a more favorable hierarchical composite points by win ratio. So whether you look at cardiovascular death, whether you look at heart failure hospitalization, and combined endpoints with NT-proBNP, everything favors sacubitril valsartan. It led to, obviously, the more powerful vasodilator. It led to a higher rate of symptomatic hypertension, but a lowered worsening of renal function. So renal function preservation was better, but obviously at a risk of slightly higher symptomatic hypertension. And finally, the pre-specified subgroup, ejection fraction below 60%, up to 60%, sacubitril/valsartan showed benefit. So the application is in the background of what we know as Paragon HF, where we knew that Paragon had failed to show a substantial benefit in HFpEF for ARNI. This trial clearly showed that there's a benefit of the primary and secondary endpoints by sacubitril/valsartan in patients who had an ejection fraction more than 40%. The final trial is very interesting, presented by Dr. Ross Campbell, called DAPA-RESIST. This is where dapagliflozin was tried as a drug to counter diuretic resistance, right? When a heart failure patient comes, we give a diuretic, and the diuretic resistance is defined as a weight loss of less than 1 kilogram or a fluid loss of less than 1 liter in the last 24 hours, despite the patient being on loop diuretic for equivalent of more than 160 milligrams IV of furosemide in 24 hours. Right. So patient came with heart failure. We are giving enough loop diuretics, 160 milligrams of IV furosemide. Patient don't respond. So it's a diuretic resistance. What do we do? Standard therapy is adding metolazone. Right. Now here they compare metolazone 5 or 10 milligrams addition compared to dapagliflozin 10 milligram once daily. Right. So dapagliflozin is an agent to counter diuretic resistance of loop diuretics. And here is the data. We see that blue in dapagliflozin, gray in metolazone, the amount of mean change of weight was kind of similar. You can see the gray and the blue overlap. So the mean change in weight was almost similar. But then if you look at the serum sodium change, here's a difference. You see that serum sodium went down far lower with metolazone compared to dapagliflozin in blue. Right. So you see very clearly there was more of hyponatremia with metolazone compared to dapagliflozin. Also, if you look at potassium, serum potassium tended to be lower with metolazone compared to dapagliflozin. Okay. So, and if you now look at the furosemide IV dose needed, you see, interestingly, the need for furosemide was more at 24, 48, 72, and 96 hours in the blue bar, dapagliflozin group, compared to metolazone. Meaning that, yes, dapagliflozin is a more gentle guide, right? So at the end of this DAPA-RESIST, what did we learn? Both diuretic strategies, dapagliflozin and metolazone, are well tolerated, effective, and they reduced the body weight similarly, right? So they acted similarly. But dapagliflozin was clearly not more effective, you can say it's non-inferior, than metolazone at relieving congestion. Okay, so it was equal. Their kind of dapagliflozin was equal to metolazone. And finally, patients assigned to DAPA tended to receive a larger cumulative dose of loop diuretic. The need for loop diuretic was larger, meaning that DAPA was probably more gentle. But this is the icing on the cake. There was much less biochemical upset or biochemical derangement by way of low sodium and low potassium with dapagliflozin compared to metolazone. Right. So obviously they were almost equal in their action, but metolazone caused less of electrolyte disturbance of hyponatremia and hypokalemia. So that is from where all this data came. Right. That is from Prague, where all the data came. And we know Prague is a beautiful city, right? It's nice. It is fascinating both on day and night. But the data that we got this time was truly fascinating, right? This is the poster of on-site and to the world data coming out. And I have put it on top of Professor John McMurray's slide, that in one slide he summarizes everything we want to follow in heart failure. One of them, I will highlight it, is we are winning the war of heart failure. Right? What a beautiful legend. We are winning the war of heart failure. Second, we need to get better evidence into practice. We need to get better by putting the evidence into practice, by giving all this for survival changing, mortality reducing drugs like ARNI. You saw the SGLT inhibitors, dapagliflozin, MRA, and beta blockade into practice. And think about it. How can we overcome physician inertia? I think if we can address these three challenges, our job will be done. Thank you for your time. And we will meet you same time tomorrow with even more interesting data that is presented tomorrow at the European Society of Heart Failure meeting at Prague. Thank you.